Good morning to all. Today we'll be discussing a very important topic, which is antiplatelet therapy post percutaneous coronary intervention. I am Dr. Karthik, Associate Professor of Cardiology at Unmicrc Institute of Cardiology and Research Center. This is a topic which comes up usually in the examinations and also has a lot of practical implications. So, we as intervention cardiologists are doing PCI day in and day out. So, antiplatelet therapy form the cornerstone of the treatment post PCI. So, what is the rationale for using antiplatelet therapy during PCI? So, we come across patients who have either acute coronary syndrome in the form of unstable angina, NSTEMI or STEMI, or you have chronic coronary syndromes. So, in a patient with acute coronary syndrome, the main reason of acute coronary syndrome is a plaque rupture or a plaque erosion. So, in these patients post PCI, the main problem which we face is to reduce the thrombus burden and to prevent flow obstruction. This is prevented by antiplatelets. In both acute as well as chronic coronary syndrome, when we do a balloon dilatation, there is an iatrogenic dissection, there is iatrogenic plaque disruption, there is distal embolization, and there is side branch occlusion. All these things increase the risk of periprocedural MI. We all know that periprocedural MI is associated with morbidity and mortality. So, antiplatelets used during this condition will prevent or reduce the risk of periprocedural damage. Also, when we put in a stent, it's a metal which is lying in the vessel wall, which is itself thrombogenic. So, by the use of antiplatelets, we are preventing stent thrombosis early as well as late. So, this chart shows you the mechanism of action of all the antiplatelets. I will not go into the detail, but this is a very basic diagram which shows that whenever there is a plaque destabilization, there is either a thrombotic occlusion giving rise to an ACS, or there is plaque healing which may give rise to chronic coronary syndrome in the future. Now, the platelets, it is the main, it forms the cornerstone of the thrombotic cascade. So, whenever there is an injury to the vessel wall or there is a plaque destabilization, the platelets reach the site of injury, they get activated, they need to get adhered to the vessel wall, and they need to aggregate to form a clot. So, platelet activation is by means of various receptors on the cell surface, and most of the antiplatelets that we are using will prevent or act on these receptors to cause inhibition of platelet activation. The most popular antiplatelet, that is aspirin, which has been in use for more than 40 years, acts via the thromboxane A2 receptor. Aspirin is an inhibitor of this receptor. The other group of P2Y12 receptors, which are ticagrelor, cangrelor, clopidogrel and prasugrel, they inhibit this P2Y12 receptor. Thrombin, which is a very important molecule and which helps in crosstalk between the platelets and the coagulation cascade, acts via the PAR1 receptor, and drugs like vorapaxar inhibit this thrombin receptor. Now, once the platelets get activated, they need to adhere to the vessel wall. Now, this is done with the help of various glycoprotein receptors, and newer drugs like Rivacept are some of the drugs which inhibit this adhesion of the platelets to the vessel wall by inhibiting these glycoprotein receptors. Now, once activated and once the platelets adhere to the vessel wall, you need a platelet aggregation to form a clot. This platelet aggregation occurs by the GP2B3A receptors, and inhibitors of the GP2B3A receptors, which are mostly intravenous, include apixaban, eftifibatide and tirofiban. So, this is the mechanism of action of most of the regular antiplatelets that we are using. This is a table showing the characteristics of the antiplatelets. So, the main antiplatelets that we use in our day-to-day practice are aspirin, clopidogrel, prasugrel and ticagrelor. Cangrelor is an IV antiplatelet which is rarely used in our practice. Apixaban was in use in the previous times but is rarely used nowadays. And we have switched to tirofiban. Now, this is the history of the dual antiplatelet therapy in patients with CAD. So, right from you can see aspirin, which was one of the earliest molecules studied, to ticlopidin. Ticlopidin is a P2Y12 receptor which was introduced the earliest, but it has hepatotoxicity and bone marrow suppression as its side effects, and hence it has been withdrawn from the market, and now it has been replaced by more safer and more potent P2Y12 inhibitors in the form of clopidogrel, prasugrel and ticagrelor. Now, clopidogrel was the preferred P2Y12 therapy for many years, But then they realized the problem with clopidogrel. Now, clopidogrel is actually a prodrug. Clopidogrel needs hepatic activation, and for hepatic activation, there is a cytochrome system in the liver, which is referred to as cytochrome 2C19. Now, this cytochrome 2C19 activates clopidogrel to its active metabolite, which is responsible for its antiplatelet effect. But what happens is that in some individuals, you have a cytochrome 2C19 loss of function allele. So, in these patients, if you give clopidogrel, the clopidogrel may not be converted to its active metabolite, and hence the antiplatelet effect may not be great. So, these patients, if they undergo PCI and they are unrecognized, what will happen is that these patients will always be at a higher MACE events in the future because of inadequate antiplatelet activity. So, there was a need to introduce more potent and more predictable P2I12 inhibitors in the form of prasugrel and ticagrelor, which we'll discuss in the later slides. So, which is the ideal DAPT? Now, when you're giving a DAPT in a patient post PCI, you have implanted a stent, all looks good. So, what is the idea? Now, you need to prevent local ischemic events. So, on the right side, you can see that this is the time panel. Now, what is the risk over time? So, once you implant a stent, the highest risk of stent thrombosis is usually within the first year, and that too within the first 3 to 6 months. So, an antiplatelet has to have its greatest efficacy in the first 3 to 6 months to prevent local ischemic events in the form of preventing very early and late stent thrombosis. Then it has to also cause or prevent plaque progression and destabilization. Now, it may prevent local ischemic events, but if it is not preventing plaque progression, then it would not be called an ideal antiplatelet. So, we require the antiplatelets to prevent plaque progression and destabilization, especially in the first 3 to 6 months post PCI. Also, when you are giving antiplatelets, these patients who have coronary artery disease, they may also have other vascular beds involved, like the cerebral circulation, the peripheral circulation. So, antiplatelets not only prevent the local ischemic events, their role is also to prevent systemic ischemic events. And finally, all these dual antiplatelets, they have to reduce ischemic events, but at the same time, they should have a very low risk of bleeding, because bleeding contributes to significantly to morbidity and mortality, and this reduction or the low risk of bleeding should persist throughout the duration of antiplatelet therapy. So, this is how the ideal DAPT regime in a post PCI patient is expected to act. Now, this is the European guidelines of how to use these antiplatelets before, during and after PCI. So, in a patient, I'll make this very simple. So, before PCI, when the patient comes to you, he is a patient with chronic coronary syndrome, you need to give the patient aspirin, which is a class 1 indication. Now, before PCI, there is no point of giving any other antiplatelet, especially if the patient is having chronic coronary syndrome. But if the patient is to undergo PCI, then you need to give only clopidogrel. The class 1 indication is clopidogrel in stable chronic coronary syndromes, but prasugrel or ticagrelor may be considered, especially in patients with high ischemic risk. We'll discuss in the coming slides what is the definition of a high ischemic or high thrombotic risk. And after PCI, in a stable patient, you need to give DAPT for 6 months, but this is quite variable. You may either bring down the DAPT duration to 1 or 3 months depending upon the patient's bleeding risk. If the patient is a high bleeding risk patient, you need to bring down the duration or cut down the duration of the DAPT, and you may also use an extended DAPT in patients who are low bleeding risk and high ischemic risk. Now, if you come to ACS, patients with NSTEMI, again, aspirin needs to be used before PCI. The routine use is prohibited if the patient is not to undergo a PCI. But if the patient is to undergo a PCI, then you need to give the patient either prasugrel or ticagrelor or clopidogrel. So, most of the Western world, and in fact even in India, we have switched over to prasugrel and ticagrelor as the first line antiplatelet or first line antiplatelet for PCI patients during and post PCI. Now, post PCI, whether it be NSTEMI or STEMI, the DAPT duration is usually 12 months, but again, as we'll discuss in the coming slides, the duration may go up if the patient is having a high ischemic risk, and it may go down depending upon the patient's bleeding risk. In a STEMI, before PCI, both the antiplatelets, that is an aspirin and a potent P2Y12 inhibitor, are indicated, and the same would be followed during and after PCI. So the DAPT duration in any ACS ideally is 12 months, but it may go up and down depending upon the patient's bleeding and ischemic risk. So at the end, what is the idea? So you need to individualize any patient's antiplatelet strategy. It is not that you can apply these guidelines to any patient. You need to take into account three things: the bleeding risk, the antiplatelet responsiveness, which we rarely do in our clinical practice, and the ischemic risk. So it's a very delicate balance between all the three, and you need to select the best antiplatelet strategy for that patient. So it is not that you can generalize. You need to personalize this antiplatelet strategy post PCI. If it's a bleeding risk, you need to look at the clinical variables, the procedural factors, and the various scores. If it's antiplatelet responsiveness, you need to look at the platelet function testing and genetic testing. And if it's a ischemic risk, you need to look at the clinical variables, the procedural factors, and the various scores which are incorporated. So this is the European Society of Cardiology ischemic risk definition that they have classified as high thrombotic and moderate thrombotic risk. So risk enhancers: diabetes, history of MI, any multivessel CAD, polyvascular disease, premature atherosclerosis, concomitant systemic inflammatory diseases, CKD, all these are risk enhancers. Plus technical aspects like more than 3 stents, more than 3 lesions, lesion length or the stent length more than 60 millimeters. If it's a complex CAD, left main, bifurcations, CTOs, vein graft stenting, more than 2 stents implanted, history of stent thrombosis, all these constitute a high thrombotic risk patient. If it's a moderate thrombotic risk, you have diabetes, history of MI, polyvascular disease, and CKD. If you come to the bleeding risk definition, the Academic Research Consortium has defined as a major criteria. So you have all these factors like use of anticoagulation, CKD again. So you can see that there is a lot of overlap between the risk factors. So a patient with CKD or a patient with diabetes will constitute both a high ischemic risk as well as a high bleeding risk. So you need to weigh the pros and cons and identify each patient and then treat the patient. So you have factors like anemia, spontaneous bleeding, then moderate to severe thrombocytopenia, bleeding diastasis, liver cirrhosis, active malignancy, spontaneous ICH, traumatic ICH, AV malformation as the major criteria. And if it's age more than 75, moderate CKD, borderline hemoglobin, spontaneous bleeding requiring transfusion, then long-term use of NSAIDs and any ischemic stroke. So how do we go about it? So there are various scores which are there, which can help you guide the duration of the antiplatelet therapy. So one of the most popular scores used was the DAPT score, and this was derived from the DAPT trial. The DAPT trial was one of the largest randomized controlled trial which tested the efficacy and safety of prolonging DAPT duration in a patient who has successfully received DAPT for 1 year without any major bleeding or ischemic events. So at the end of 1 year, you find that there is a confusion. You don't know whether you need to continue or prolong the DAPT or need to stop the DAPT. So what you do is you calculate this score, which has all these variables, and then if the score is less than 2, you need to stop DAPT, and if the score is more than or equal to 2, you can prolong the DAPT. This is another score which can be used at the time of discharge. Say you have done a PCI and you want to discharge the patient the next day, you calculate this precise DAPT score. This is basically to predict the bleeding events at 1 year. If you have completed a successful PCI and the patient is requiring a DAPT, then you calculate the score, and if the score is say less than 25, then you can give the patient a standard DAPT for 6 to 12 months. If the patient is a high bleeding risk patient, you need to shorten the DAPT to as low as even 1 month if the patient is extremely high risk. And if the patient is moderate to severe bleeding risk, you may curtail the DAPT to 3 months. So you now after discussing all this, now you have done a PCI, the patient is okay. So your idea of giving antiplatelets is to prevent further or future ischemic events. In the future, you don't want any MACE in that patient. And at the same time, you need to balance the risk of bleeding. You don't want the patient to bleed. So we'll discuss what are the strategies to reduce the ischemic events. So the first strategy obviously is you use a potent P2Y12 therapy. right? The more potent the molecule, the more effective will be the antiplatelet suppression, and the more effective the more the reduction in the MACE rates in the future. So the two most potent P2Y12 therapies that we generally use is prasugrel and ticagrelor. Now if you look at prasugrel was tested in the Triton-TIMI 38 trial, and this was a trial which was done in ACS patients who were to undergo PCI, and at 15 months you can see that the use of prasugrel reduced MACE by 19% at 15 months. And this was predominantly because of a reduction in the MI in the patients who were undergoing PCI. So the future risk of MI was significantly reduced, and that was responsible for the reduction in the MACE events. But there was a significant increase in the non-CABG related bleeding, around 32% increase in non-CABG related bleeding, and hence at the end of this trial, the going by the subgroup analysis and the various subgroups in which prasugrel could be harmful, the investigators decided that if the patient was more than 75 years of age, body weight less than 60 kg, and having TIA or ischemic stroke, then prasugrel is better avoided. Then came ticagrelor. Ticagrelor was tested in the Plateau trial, again, which showed a 16% reduction of MACE at 12 months in patients of ACS. Now the advantage of ticagrelor was that these patients in the Plateau trial, they were either managed invasively or non-invasively. So you had patients who were also medically managed, and in invasively managed patient, you had both patients who were managed with PCI as well as CABG. And you can see that there is a 16% reduction of MACE at 12 months. But again, there is a significant 25% increase in non-CABG related major bleed, although the total incidence of major bleed was significant, not significant between the two groups, but the non-CABG related bleeding was 25% increase, and the dyspnea was another side effect seen in 15-22% of the patient. So these are the various trials which have shown that potent P2Y12 therapy may be useful, and which have also compared prasugrel and ticagrelor, but we have not come to a conclusion, and larger randomized trials would be required to differentiate between ticagrelor and prasugrel. The second thing which we can do is guided escalation of P2Y12 therapy. So this is something which remains more or less research oriented. We have not been doing it so much in our clinical practice. So you need to identify patients on clopidogrel who are either having such pharmacogenomic profile in the form of loss of function allele of the cytochrome 2C19, or you need to have identify patients who are having high HPR or high platelet reactivity on the platelet function tests. Now based on this, there are two levels of research which have been performed. In the first, escalation was compared to standard therapy. That is, suppose you have a patient, you have done PCI in that patient, the patient is on clopidogrel, the patient has had a MACE event. Now you test the patient for either high platelet reactivity, or you identify, do pharmacogenomic testing, you find that the patient is having a loss of function allele, and now you escalate the P2Y12 therapy. After identifying these patients, you escalate the P2Y12 therapy. But all these trials, which I will show you in the next slide, have not shown a benefit of escalating the P2Y12 therapy. The MACE events remained the same. Now the possible reason for this is that most of these trials were underpowered. They had a very small sample size. The definition of high HPR was not properly defined, and that remains a major hurdle in defining what is a high HPR, because most of these platelet function tests are non-standardized. You cannot have a particular value which can be called as a high HPR. And also the proper escalation of the P2Y12 therapy was not there in most of these trials, and hence all these trials failed to show that if you identify these patients and then escalate, then it would not be beneficial. So the other group, what they did was they had a series of trials and all patients who underwent PCI. So what they did was that the patients underwent a PCI, they were tested for either a pharmacogenetic testing was done or a platelet function testing was done. They identified patients who would not respond to clopidogrel, and directly they put those patients on ticagrelor or prasugrel. So these trials, which include trials like the Taylor PCI, although not significantly positive, they have shown a trend that if you do this, then there is a trend towards decrease in the MACE rates. And if a large randomized trial planned in the future would show that if you go for platelet function testing or pharmacogenetic testing, you identify these patients and then you put these patients from the beginning on ticagrelor or prasugrel, then it would result in long-term reduction in the MACE events. Now this is how you switch. Now suppose you feel that you need to escalate or de-escalate, how do you do it? Now there are two ways of doing it, one in the acute setting and one in the chronic setting. So acute setting is a recent ACS patient, so it's very simple. So when you go from clopidogrel to prasugrel or prasugrel to ticagrelor or clopidogrel to ticagrelor, you always need to load. Just remember this line that acute setting always reload. You always need to give a loading dose of the drug, 60 milligram of prasugrel, 600 milligram of clopidogrel and 180 milligram of ticagrelor. But when you're going from prasugrel to clopidogrel, at least you need to wait 24 hours after the last dose of prasugrel, and when you're going from ticagrelor to clopidogrel, again you need to wait for 24 hours. But if you need to de-escalate from either prasugrel or ticagrelor to clopidogrel, you need not wait. You want to up or escalate from clopidogrel to prasugrel, you need not wait, and you can directly go for a loading dose. In the chronic setting, you don't need to load. Usually you don't need to load. It is only when you are switching from clopidogrel to ticagrelor or ticagrelor to clopidogrel, you need to load clopidogrel in these patients, and you are going from say ticagrelor to prasugrel, you need to load, and that is primarily because ticagrelor's action is mainly reversible, very short acting drug, and hence the loading dose is required. But in most of the other cases, loading is not required. So one thing which we have studied is that you use a potent P2Y12 therapy, you go for guided escalation of the P2Y12 therapy. The third thing is prolonging the DAPT duration. So which was the trial which showed that this is beneficial? The DAPT trial, which I have already told you, that around 10,000 odd patients who underwent DES placement, they were free of MACE at 12 months after the procedure. They either received DAPT with either clopidogrel or prasugrel, they were randomly assigned to receive it for 18 more months, or they received placebo. All the patients continued to receive aspirin. The primary endpoint was definitive or probable stent thrombosis. The secondary endpoint was MACE rates, and primary safety endpoint was moderate to severe gusto bleeding. So you can see that the major adverse events came down significantly with the use of DAPT. But if you carefully identify the patients, then the bleeding risk may also not increase. This was another trial in which stable patients were taken who had a history of MI 1 to 3 years prior and with another risk factor, and again it showed that if you carefully select patients and give them DAPT, then the ischemic events may be similar to using aspirin plus clopidogrel, and if the bleeding rates may remain same. These are the various trials showing a prolonging of the DAPT duration, right from the DES late, Prodigy, DAPT, Arctic interruption, Italic, Pegasus TME54, OptiDual and Themis trial. This is the whole chart right from the year of inception to the current era, where the results are, the trials are still ongoing, which show that further de-escalation or prolonging the DAPT duration, whether it is useful or not, whether you need to go for a guided escalation, all these trials are still ongoing. So now you have reduced the ischemic events. How do you reduce the bleeding events? So first, the opposite, shorten the DAPT duration. So you have all these trials like Excellent, Reset, Optimize, Security, ISAR Safe. So as you see, as the trials have evolved, you can see that the duration keeps coming down. It was initially 6 months, then 3 months, and now the last trial, which is the 1 month DAPT, has shown that even in carefully selected patients with high bleeding risk, a 1 month of DAPT versus 6 months of DAPT is useful in preventing MACE, and at the same time the bleeding risk also comes down significantly. Then the P2Y12 monotherapy. Now this concept has come from patients with atrial fibrillation who undergo PCI. So the idea was that you give the patient aspirin, clopidogrel and anticoagulation for a week, and then you give the patient for 1 year a single P2Y12 monotherapy and anticoagulation, and then after 1 year you put the patient on oral anticoagulation. Then they found that most of the trials like the Redual PCI and the Redual PCI trial, they found that in the Pioneer AF trial, they found that this is a very good strategy, and at 1 year the MACE rates remained the same and the bleeding risk was significantly lower rather than using a dual antiplatelet plus anticoagulation. So this is the P2-ITL monotherapy. One of the largest trial was the global leaders trial. In ACS patients, they had ticagrelor monotherapy for 23 months versus DAPT with ticagrelor for 12 months. And they found that the primary endpoint of MACE was significantly lower or was similar to the DAPT arm with a significantly lower safety endpoint, or the bleeding risk was significantly lower in this group of patients. The twilight arm was ticagrelor monotherapy after 3 months of DAPT versus standard DAPT in high risk PCI. Now this was a very important trial because after 3 months of DAPT, you are switching to ticagrelor monotherapy, and this group of patients were they were high risk patients who underwent bifurcations, they had CTOs, and so the bleeding risk, you can see that is significantly lower in the monotherapy arm as compared to the DAPT arm. So if the ischemic endpoints are same, or the ischemic events remain same, this is a very good therapy which can be given after 3 months of DAPT. The recent STOP DAPT and TICOS trial have also been published, in which ticagrelor monotherapy has shown that the ischemic and the bleeding risk is quite similar to using a DAPT for a prolonged duration. Then guided and unguided de-escalation of antiplatelet therapy. So this is just the opposite of what we have studied in the previous slides. So what happens is that you identify the patients who are responders to clopidogrel, and then you give the patient clopidogrel after putting them on a potent P2-ITL inhibitor for say a month or so. You de-escalate and go with aspirin and clopidogrel, and although these trials have not shown a positive result, but still they are a step in the right direction, because most of these trials again were underpowered and had a very small sample size, and the future trials may show that guided de-escalation may be useful in preventing bleeding events. This is the unguided de-escalation, which is not preferred. So I'll just come to the end of the discussion where you have atrial fibrillation in CAD in post PCI patients. So if a patient is having already AF and you need to do a PCI, then you need to take care of the following pre-procedure considerations to be taken that define the appropriateness of the PCI. In ischemic, thrombotic and bleeding risk stratification is required. The procedural considerations are you need to prefer a radial axis as compared to a femoral axis. Stent selection, preferably a new generation DES is preferred, and post procedure you need to closely monitor the patient's risk profile and recommend use of PPIs and avoid NSAIDs. So as I already told you, if the patient is undergoing a PCI and as a AF, then you give the patient aspirin, preferably clopidogrel, and an oral anticoagulation. Now the oral anticoagulation may be a NOAC preferably. Give it for 1 week. If the patient is say very high ischemic risk, you may give it for 1 month, but after 1 month the use of aspirin is not recommended. Stop the aspirin, go for clopidogrel plus a NOAC, say rivaroxaban or dabigatran, give it for 1 year, and then after 1 year stop the antiplatelet and put the patient on lifetime NOAC. This is how the patients with an indication for oral anticoagulation goes. As I told you, 1 week to 1 month of dual antiplatelets plus anticoagulation, going up to 12 months with a single clopidogrel monotherapy or with a NOAC, or aspirin monotherapy with the NOAC, which is not preferred. And then if the patient is very high bleeding risk, you just give it for 1 week and then switch or give the anticoagulation and antiplatelet P2-ITL monotherapy for 1 year and then lifetime anticoagulation. So the take home message is that antiplatelet therapy represents the cornerstone of treatment for prevention of local and systemic ischemic complications in patients with CAD undergoing PCI. The intensity and duration of aspirin and P2-ITL inhibiting therapy should be adjusted to reduce the risk of ischemic complications while minimizing the risk of bleeding. It's a very delicate balance. See, most of the patients who are elderly and who are having CKD, diabetes, all these patients constitute a high ischemic risk and as well as high bleeding risk. High ischemic risk because most of these patients have complex CAD, and high bleeding risk because of their associated risk enhancers, and hence an integrated approach including scores, definitions to define ischemic and bleeding risk, procedural characteristics and tools to help assess drug response represents the most promising approach for a personalized section of antiplatelet agents among patients undergoing PCI. Thank you.